Welcome back. Continuing the discussions on healthcare research with a particular focus on India. Today we will look at evidence. Now the practice of healthcare is now considered to be an evidence-based practice. Evidence-based clinical practice, evidence-based public health practice, evidence-based medicine. And it hinges, or its foundational base for every action is the evidence that that particular action is beneficial or gives more benefits than harm. That's where the term evidence-based medicine comes from. So you're basing your clinical practice, you're basing your public health practice, you're basing every action that you're doing on certain evidence. So let's look at this evidence more carefully. Now it's important to understand the evidence from the perspective of someone who practices healthcare, who is a practitioner, irrespective of the stream of medicine that you are practicing. We leave those arguments for a later time. But irrespective of the stream of medicine that you're practicing, healthcare practitioners must consider the evidence that what they are practicing actually benefits or leads to an improved outcome for the person, the individual, or the society. As opposed to an increased harm either to the person or to the society that comes from that particular practice. It's also important from the perspective of the person who is receiving care to know that whatever is being administered to them or whatever is being recommended to them or is being advised to them has got the weight of evidence that it works for most people behind that particular advice or intervention. So evidence is an important part of that whole spectrum of providing care and the interactions between the healthcare practitioner and the person receiving that care. So one very key important aspect to understand here is that, as in most things in life, evidence comes on a scale. So it can be a very strong evidence that something works. It can be a marginal evidence that something possibly benefits. And there is a balance that has to come in. A balance that comes into the entire picture as you advise or recommend a particular line of management. That's something that has to be done, both by the practitioner as well as by the person receiving the care, that there is the possibility that it may not work for someone. There is a possibility that it will work for most people. The keyword being most people. It works for most people. For some, it may not work. So that possibility is always, when we say evidence-based medicine, when we say based on evidence. So if the practice of medicine, if the practice of healthcare is based on evidence, it then becomes essential that we understand the evidence. Our entire practice is based on that. That's a foundational bedrock. And it's important that we understand the foundational bedrock so that we can then move forward. And when we look at evidence, it's essential that we take a step back and then start from the beginning of what has led to the creation of this particular evidence. And that starts from the question that you sought an answer to, the question that a healthcare practitioner seeks an answer to when he or she sees a patient, the question that a patient comes to the healthcare practitioner. I have this problem. What problem do you have? What am I seeing? What is my examination showing? And then what? I'm putting whole set of information together and then collating it, assimilating it, analyzing it, and then reaching a certain level of evidence that something can be done. This is that, this is X, and it's best treated with Y, or something like that. So the question, the primary question, is very important. And when you look at the evidence for any particular procedure or drug, medicine, or whatever, sign or symptom, you have to carefully consider the question that led to the development of evidence with respect to that particular sign or symptom or intervention. Needless to say, very clear, specific questions provide you clear, specific answers. If your primary question itself is vague, it's not well defined, it's unfocused, the chances that you will get a very clear, specific answer is lower. So if a study that is looking to generate evidence does not have a clear, specific, very focused, precise question for which an answer is being sought. To paraphrase that, if the question is vague, ill-defined, unfocused, you're not going to get clear, specific answers. And if you don't get clear, specific answers, your ability to apply that evidence onto a patient, a population of patients, diminishes. So the question becomes very important. The ability to frame a question, the ability to clearly think through the question that you want the answers, taking time to understand what is it that you're really seeking. What is it that you really want to understand becomes important in the whole framework of developing evidence. If the question is not clear enough, if it's vague, it's imprecise, that whole structure of evidence becomes shaky. And once you have framed your question, then you have to frame the methods to answer that question. And we need very clear methods to answer the question. And each question has got a particular path of methods that will provide you the best or optimal answers for that particular question. And we need to see if that particular path has been followed. In general terms, these are known as the study designs. The design of a study to obtain optimal answers to a particular question. And because there may be similarities in questions, you can have a particular design be applied to a particular set of questions. So the design. Now the design involves the processes and the methods that are used to answer that particular question. And the whole idea of the design, it's not like it's a strict box out of which you cannot move. The idea is that that forms a base structure. And then it gives you the most optimal pathways to answer that question. And it might happen that there are times that you might have to deviate from that pathway a little to get a more optimal answer or a more optimal pathway to reach the answer. These adaptations are possible. These adaptations are allowed. But to understand these adaptations, you have to understand the basic box very well. When you understand the basic box very well, you know where it's strong, you know where it's weak, you know where you can make an alteration to make it strong. You know where, if you make an alteration, the whole box might become weaker. To do the alterations in the box, you have to know the box. And you have to know the basic design. So this is what a study design is. It's a process that is designed to help you get the best answers to your question. And it involves several components, including where are you doing the study? Where are you collecting the evidence? On whom? From whom are you collecting the evidence? The study population, the time, when, how are you collecting the evidence? What processes are being used? Who collects? When is it collected? Why is it collected? Why are you looking at that bit of information? How is that information stored or documented? How do you plan? How do you use all this information? That's the analysis of the data. And how do you interpret? How do you plan to interpret all that information that you are collecting? So all of that forms part of the study design. And it's a very key part of knowing if the pathways that have led to this particular bit of evidence is robust or strong enough. So to do a small recap, when we look at a bit of evidence, we have to look very carefully at the question that led to the creation of that evidence. Yes, is that question precise? Is that question specific, well-focused? And then we have to look at the processes that were used to get this bit of evidence. And are they robust enough? Are they appropriate? Every question has got an ideal pathway to seek the most appropriate answer, an optimal path, ideal path. An ideal pathway and an optimal pathway may not always work in real life. And so every question then has an alternate path. And once we know the strengths and weaknesses of the ideal pathway, we will be able to make out, given our situation, given our setting, whether an alternate pathway can be used or has to be used. And we can look at the strengths and limitations of the alternate pathway as well. So, if you notice carefully, there is a subjective element that comes here in the design of the studies. And the subjective element comes in the form of what is the most pragmatic way to get an answer, given the resources that I have in my setting. And that's acceptable. And that has to be accepted. If we are able to find answers, if we are able to encourage and motivate people to find answers to questions from different settings that matter to them, answers to the questions that matter to them and their patients. So we have the study design. And then we have the data that has come. We have analyzed the data and we have got evidence. Now, evidence is not a black and white box. It's a box with a lot of gray in it, more than 50 shades of gray, a lot of gray areas. And a lot of gray areas because the person interpreting the evidence is a human being, and the human brings in an element of subjectivity to it. Even though you have objective criteria set in, you can have an element of subjectivity that comes into the final interpretation. Then the human being, the human mind, interprets all that objective criteria. It brings in an element of subjectivity of the individual person. So when I see a paper and a bit of evidence, I might interpret it as a high quality evidence. An equally accomplished peer might interpret it as a moderate quality. It's not high quality because I feel certain things were not there. I might say, well, given their setting and knowing their setting, I think that that is acceptable and I think it's still high quality. So this element of subjectivity comes in. And the element of subjectivity usually comes in the processes and the methods that are being used. Now, if you listen to my previous talk where I talked about how resources, the availability of resources vary at different settings and how that can affect and can impact upon research. So we can see that at play here, where a primary care setting might not have access to the top-end technology and might use what is available there. Do we call that as low quality evidence because the processes are using less than the accepted global standard? Do we say that it's high quality evidence just because it is used only or all the high-end technology or the high-end instrumentation or the high-end methods that are available? So this subjectivity comes into play. And you can now see that evidence then comes on a scale. It comes as a scale. It can be very high evidence. It can be very low evidence. High quality evidence, very low quality evidence. And in between you have low quality evidence, moderate quality evidence. Then you have the high quality evidence. So the high quality evidence comes where you say with certainty that whatever you have seen, whatever the evidence is there, is actually extremely similar, very, very similar to the truth. If it's an estimate of risk, it's very similar to the actual estimate of risk. If it's effectiveness of an intervention, it's actually very, very similar to the effectiveness of the intervention in reality. So that's a high quality evidence. A moderate quality evidence is where you say that, well, it is not exactly similar or very close to the reality, but it's close enough. And if you do more studies, maybe we will find it coming closer and closer to the reality, the real picture. That's a moderate quality evidence. A low quality evidence is where you say that, well, there is a big difference between the evidence that has been collected from the studies and what we see in practice. We see something very different. It's not too much similarity there. I would say that most of the times I see something different. It's a low quality evidence. A very low quality evidence is where we say that, well, almost all of the times, what you presented as evidence is not what we see in actual clinical practice or actual public health practice. So you can see there are different grades of the quality of evidence. So when you present the evidence, when you read the evidence, you're then naturally going to have to look at what is the quality of this evidence. And the quality of the evidence is assessed based on several factors, including the questions that have been asked, whether they are precise, focused enough, the methods that have been used, the populations that have been studied, the time frame in which the study has been done, the definitions that have been used, the investigation modalities that have been used, and the various bias that creeps in the selection of patients, in the selection of outcomes, in the measurements of outcomes, in the measurement of values, in the methods that are used. So an assessment of all of this. And are you looking at bias from two aspects? You're looking at problems from the study itself in the process of doing the study. And you're also looking at problems in the interpretation of the results. Problems in what outcomes have been looked at and in the interpretation of the results as well. So here we can see a large amount of subjectivity creeping into a very objective framework. And that is understandable, and that happens. And what we need to be aware is that there is this element of subjectivity, and we need to step back and look at the evidence, look at all these parameters, and then make a definitive conclusion on the quality of the evidence, linking or aligning that with our clinical practice and what we see with our patients in real life settings. The key then is that we need to be aware, and we need to have evaluated what we see, our experience in our patients, not as speculative opinions, where we tend to remember the best case scenario, we tend to remember the worst case scenarios. But the majority are in the middle, whom we may not always recall or remember because they're not striking enough. And so evaluation of our experiences, evaluation of our clinical practices, evaluation of our outcomes becomes an important call, an important step in our evaluation of the evidence that is out there, and then trying to apply it. Keep that aspect in mind. That's a very important aspect. Now, it's not just enough that we have this evidence sitting there and grade that as high quality, moderate quality, low quality, very low quality. A high quality evidence need not always lead to a recommendation that it has to be translated into practice. So you have to take this bit of evidence, and then I have to say, well, now, what is my recommendation? Can I recommend that this be translated into practice for everyone or for the vast majority? So now we bring in the bridge between evidence and recommendation. And along that path, along that bridge, which can be a lonely bridge at times, unless the evidence is of such a high quality, along that path, we have to consider all the questions that we look. The patients on whom we are going to apply this, are they similar to the patients that were studied, the patients from which the evidence was generated? If they're going to be different, then can I still say that it's high quality evidence and I should apply it? Or do I have to put in an asterisk there, a mark there, to say that we need to think of that? We need to think about this a little bit more. The processes that were used. I've used all higher end technologies. Advanced tertiary care setting. Can I take that and apply that high quality evidence as it is to a primary care setting where I don't have access to all these higher end diagnostic therapeutic modalities? The recommendation has to be thought over. I have got a high quality evidence from a primary care setting. Can I recommend that to be applied across all settings, including a tertiary care setting? But things might be different because the patient population accessing the tertiary care centers are different. They have greater grades of severity as opposed to a primary care setting. So again, the recommendation has to be tailored. Now, usually when we look at study designs, we say, well, the randomized clinical trial is the highest level of evidence. And above that, among the higher levels of evidence, above that, you have the systematic reviews, which are reviews of multiple studies, meta-analysis, systematic reviews of systematic reviews, and moving ahead. And down, you have the speculative opinions from authorities, you have the case reports, individual case reports of individual patients, a case series, you have various observational study designs, and you have a hierarchy of evidence. So let's say that we are using the systematic review as a very high level of evidence, and you say that, well, this bit of evidence comes from a systematic review. Automatically, it's a high quality evidence. You place it the moderate to high quality evidence, and then you start reading through and you start looking through the systematic review, and you find that the papers that have been included in the systematic review have got methodological issues. Now what happens? You have to start bringing down the grade of evidence that you have placed. You find that there are poorly done studies. There are only very few studies of good quality, and hence you have a very small pool of studies. Patient selection has not been appropriate. It doesn't really match with the patient population that I see. The risk factors are different. The definitions are different. The methods of ascertainment are different. And then you start looking at all these factors, and then you say that, well, I either retain the initial grade that I have given, or I have to bring it down. So it can move. You can take a case control study or a cohort study, and then you can look at the magnitude of the effect, and you find a very large magnitude of effect, very large difference, very large effect size. Like I said, well, even if there have been problems, just by its sheer, the large size of the effect size, at least a small effect size might be there. And so you say, okay, then I can shift this up slightly. I can look at a dose-response relationship and say when the dose increases, the responses improve or changed accordingly. I can again, so that shows me that there is a relationship between X and Y. As the dose of X increased, Y changed. As the dose of X decreased, Y decreased. Now that can be in terms of risk, exposure to a risk and an outcome, or it can be even in terms of medicines that are given, interventions. So again, I can scale up. So I can say that a lot of residual confounding factors are there, and they have been accounted for and adjusted for in the study. And still there is a good effect, a big good difference that has come out as part of this study. And I can again scale up. So you can see that we can scale down and scale up the level of evidence as we look at the component studies that make up the body of evidence. So it's not like a fixed set in stone. Just because a particular design has been used. It often happens that we hear people tell that the best quality is a systematic review. A systematic review has been done, and this is what it says, and it is a high quality evidence. No, you have to critically evaluate that systematic review. A randomized controlled clinical trial has been done for this intervention study. It is the gold standard, and hence it is high quality evidence. No, it may or may not be. You have to analyze the process, starting from the question, the entire design of the study, and the analytical methods used, and the interpretations, and then say, is it still high quality, or do I have to peg it down? So you're looking at all of this, and now you say, I want to make a recommendation. We can look at two broad recommendations. One is a very strong recommendation. And you can use a very strong recommendation when you're absolutely certain that this bit of evidence leads to significantly greater benefits than harm. Or this bit of evidence leads to significantly greater harm than benefits. So the difference between the benefit and the harm is large. It's a strong recommendation. You can say use it, or you can say don't use it. There's no ambiguity there. Clear. If something is so clear, then there is something where there can be a bit of gray creeping in as well. So you have the not so strong recommendation. We can call it a weak recommendation. We can call it a conditional recommendation, several names. That is where the gap between benefits and harm is not large. And you now have to sit and think over, well, given this harm, Do the benefits outweigh that? An example would come in cancer therapy, cancer care, where you would look at chemotherapy or radiation therapy and then say, given the harms, the potential for harm, and the benefits, should we do it or? A more recent example would be the use of computerized tomography imaging of the chest in COVID patients. And again, looking at it, given the risk of possible radiation exposure in a younger population, repeated CT studies, and the benefits of identifying COVID earlier, possibly, and initiating therapy earlier, and monitoring progress, triaging. Do we do it? Do I recommend that it should be done? Now, where it is a big difference, it's clear, it's clearly beneficial, it's clearly harmful. The recommendations can be made easy. A lot of medicine does not fall into such clear-cut boxes. Where it's not so clear, you need shared decision making, where you're then sitting with a multidisciplinary team, looking at all the evidence and then synthesizing all of the evidence and then saying that, well, based on all of this, we recommend that. It's a weak recommendation, but we recommend that this can be done. Or this need not be done at this time. Even though it has these benefits, the harm outweighs the benefits. Or even though it has these harms, the benefits outweigh the harms. And so it can be done or need not be done. So those are the two types of recommendations that come. Now the recommendations have implications for the person practicing medicine. Should I do it or not do it? If it's a strong recommendation, I know I can do it. If it's a weak recommendation, I have to then bring in my analytical skill, my clinical experience, my patient population, my patient characteristics, my skill levels into the mix to make a decision. Should I do it or not? If it's a healthcare policy maker, a government, an institution, an insurance company, they also have to weigh the benefits and the risks, and the decision making has to account for several factors, including the prevalence of the condition, the magnitude of the condition in the society, the equity that's associated with it, the distribution of care, the resources that are available, a whole set of costs that associated with it, a whole set of decision making processes around. Think over this. I would like to leave you with two thoughts particularly, two thoughts. One, that be aware that the statement that this is high quality evidence does not translate into application as it is. The statement that this is weak, low, moderate quality evidence, low quality evidence does not translate into application or do not apply as it is. It has to be analyzed and then worked into a recommendation. The recommendation can be a strong recommendation. A strong recommendation need not necessarily be applied to all people as a practice. The issue of cost, the issue of equity, the issue of resources, the issue of skill, all come into play. A weak recommendation need not be discarded as it is. Again, a weak recommendation in the hands of a highly skilled practitioner, well-versed and well-experienced in that particular niche area, with the support of skilled human resources and instrumental and technical resources, can still apply the weak recommendation with good outcomes. So, evidence is an extremely important part of clinical care. but has a subjective element that has to be acknowledged and accepted and understood and worked upon. To work upon that, we need three very important things. The ability to observe and think critically, critical thinking, observations, seeing observations, registering observations, documenting observations, and critical thinking. We need to look at the way that questions are framed and the processes to answer questions, clinical epidemiology, research methodology. We need to also look at the way that the collected data is analyzed, the evidence is built up from the data and analyzed and interpreted and synthesized to reach a final output. Call it the statistical part of it. So we need critical thinking. We need research methodology, clinical epidemiology. We need statistical analysis. Three core parts coupled with your experience, your clinical experience on your patients, and ethical and legal obligations. So for evidence-based medicine to succeed, evidence-based medicine has to be practiced by every healthcare practitioner in its entirety, not in bits and pieces, not as second-hand information, because the evidence has to be synthesized with your clinical practice, your clinical skills, your clinical experiences, and your clinical patients, or your public health practice, your public health experience, and the population health in the areas that you work. So when we say evidence-based medicine, let's spend some time thinking over what is evidence and what are we doing with that evidence and how are we approaching the whole bag of evidence. See you next Sunday. Stay safe, be happy, and let's continue talking. Thank you so much.